That's absolutely fine. And can you just put in the chat when that's started so that we can then make the introductions, please? Okay, thanks very much indeed. Welcome everybody to this governing body meeting held in public, July the 14th. The meeting is being recorded and it is also being live streamed. Okay, so I've received apologies from Deborah Shepherd, Alison Smith and Zena Young. I don't know if anybody else has any additional apologies to add to those. No, okay, thank you. So moving on to members' declarations of interests. The declarations of interests have been included in the pack. Do any members present have any additional declarations of interest to make, particularly pertinent to today's agenda? Okay, I take that as no. Super. So moving on to my introductory comments as chair. I'd normally at this stage reflect upon the agenda items that we've got ahead, but instead today I just really have a simple message. We have decided as a board to be cautious and conduct this meeting virtually rather than in person today. And I believe that decision has been shown to be fully justified. Clearly, we're at a different phase of the pandemic now. We have significant numbers of adults who have received both of their vaccinations against COVID-19. But at the same time, we're also seeing an exponential rise in COVID-19 infections once more. And this is all in the context of the government's relaxations of the restrictions on July the 19th. So I would ask our public and providers to remain vigilant, to maintain good practice of hands, face, space and fresh air. People should meet up outside where possible, should keep windows open when meeting inside, and people should wear masks in crowded spaces, but particularly so in healthcare settings, both primary and secondary care, where of course those who remain vulnerable to COVID-19, including those patients unvaccinated or immunocompromised, for example, are present. We've all got a duty to consider and protect others around us, and continuing to wear masks in healthcare settings remains vital at this time. This is also in line with the ongoing Public Health England guidance for maintaining services within health and care settings, namely that patients and those accompanying them will be asked to wear a mask, a face mask covering at all times. So really that's that simple message for us to remain vigilant and keep those measures in place in healthcare settings. But the overall situation is certainly positive, particularly with our vaccination record. Okay, thank you. Over to you, Claire.
Thanks very much, John. So there are a few things that I wanted to highlight to board that have happened since we met last time in public back in May. It feels like those weeks have absolutely flown by, and as ever we're very busy as a team, and there's lots of things going on. So just to bring a few highlights from what has been a very busy schedule for us all. First of all, I just wanted to touch on the NHS England board to system meeting that I attended back on the 8th of June with other system colleagues. So this was a meeting with the national team, including Amanda Pritchard and Julian Kelly, Ruth May and others from their team. And we had opportunity to showcase the hard work that we're putting in as a system around our recovery. And that's not just the financial recovery, that's all the other work we're doing to support SATH with their endeavours around some of their quality issues, and the work we're doing to come together collectively and create that identity that we want as a system. So we had really good feedback from that meeting. The team could see the positive progress that we're making, which as a team that went to present, we were really pleased with, because that was what we wanted to make sure that we could put across. Notwithstanding, we all recognise that we've still got a long way to go, and that's where we're focusing effort and energy at the moment. Mark Brandreth and I have the pleasure of another session with Julian Kelly, the National Director of Finance, on the 22nd of this month, so next week, and we're going to give him an additional walkthrough of the progress that we're making with our financial recovery plans, because he's interested to get into the detail of some of that. So watch this space, and we'll give some feedback from that as well. I wanted to touch on the submission of our annual report and accounts. So we met to consider those and sign them off as a board a while ago now. And if you recall, we also gave delegated authority to a small group of us to accept the final version of the auditor's report. The accounts, annual report, all of the associated documentation was submitted on time, which is fabulous. We did our review of the final audit report, and I'm pleased to say that the content of that report, some of the errors that were noted, we were able to reduce before that final version was produced. So we didn't have a difficult job in reviewing and signing that off on behalf of the board. Did want to just point out an emergency action that was taken just prior to submission. We spotted a text error in the Telford and Wrekin annual report, and Alison and I thought that there was no need to reconvene a full governing body. We literally had to change one word, so a select group of us agreed that was okay to do, and we just hold that on record here that action was taken. For anyone that's interested, deep buried in the narrative in that report, there was a reference to a surplus that should have been a deficit. One word, but what a big difference. So that's been corrected, and the public version holds the correct record. I also wanted to mention the improvement assessment framework, the IAF, for last year, 2021. Those of you who have been around in CCGs for a while will recognise that annually we're assessed on a number of criteria in that framework, and we receive a rating, an annual rating for the CCGs. For last financial year, given the difficulties and challenges around that year, the full process was stood down, and instead all CCGs were asked to prepare a self-assessment that our regional team then reviewed and gave feedback on. We don't get a rating this year. Because of our position as well, we were allowed to submit a combined self-assessment, so we didn't have to go through the additional burden of self-assessing the two CCGs, so that we were grateful to NHSEI for being pragmatic about that. We have received our feedback from NHSEI. I can circulate the letter to board members after this meeting. That's no problem at all for information. The assessment that was given was balanced and fair. It certainly reflected our judgment of what we'd achieved last year and some of the things that we've moved on and the things that we still need to work on. The areas of focus highlighted in that report are those things that we know about already and we're working on. So again, I was comfortable that we weren't seeing any feedback there that was cause for concern, because we're already on the case. So the 4 areas, as we'd expect, is to keep focusing excuse me, on service transformation. There was an emphasis for us to continue our work around improvement of quality of services and our CCG surveillance of that. An emphasis on us focusing on recovery of services, again a big thing, and I know Julie will talk lots more about that in the agenda. And we can't finish the list without talking about meeting the financial plan. So as I say, nothing in there that comes as a concern or a surprise. They're the things that we know we need to continue to work on. ICS development continues at pace. We're seeing more and more information coming through, but I have to say that at this moment in time it's more of a trickle than a deluge. So the framework was released a couple of weeks ago. We believe that there's a large amount of guidance imminent, and certainly we've had the first reading of the bill go through Parliament now, so that's moving on over the next few weeks. We have set up now a transition group within the system, because we recognise that this is a huge task, not just in developing the model for what the ICS looks like and its governance and all of that, but actually we have a task to wind down the CCG. Alison and I sit on that group with various other experts in their fields from across the system, and we are overseeing the process for making sure that that transition occurs smoothly. So we're pulling in relevant people from within the CCG, and absolutely we're using our experience, our recent experience of bringing the 2 CCGs together to make sure that we're managing risk there. So I'm sure that there will be more reports through here, well, through audit committee, similar to how we managed the CCG work, so that the board can receive its assurances that we're managing that and we're managing any risks associated with it. Couple of last quick ones from me, just to confirm to the governing body that our move to Ptarmigan House is complete. William Farr House we have exited from. We've seen a few teething problems, which is only to ever be expected when you do a move like this. The teams have been absolutely fabulous in packing everything up, and for those teams that have moved into Ptarmigan have been really helpful in terms of their patience whilst we iron out some of the bugs that are happening, but certainly that's complete. Next step for us, and certainly very mindful of next Monday's relaxation, is that we are looking to finalise and promote our agile working policy. So certainly we've taken some time to reflect on the last 12 months and the benefits of a more blended approach to working between home and office where that's appropriate. We've been talking to staff about that. We've taken their feedback and we'll be developing that policy. The message to staff at the moment is very much be patient, wait until we tell you what's happening next. We are not encouraging any large-scale return back to the office at the moment. We want to make sure that that working environment is safe for our staff. So very much ties in with John's previous message. And finally, just a quick note on the vaccination programme itself. We are on track to achieve 85% of our adult population receiving at least 1 dose by the time we get to next Monday. That's down to the hard work and effort of all the teams that are working to support the vaccination programme. Not all areas are able to say that they can achieve that, so it's a big great thing for us as a county. We've now administered well over 650,000 doses of the vaccination. Again, huge effort within primary care and our vaccination centres. And the boring planning bit of it, we know that phase 3 is coming. We're taking the guidance as it comes through, but we're already well into our planning for how that will work. And certainly Sam is looking to consolidate our vaccination programmes where we can. So we're looking for efficiencies in our flu and COVID programmes and governance, so that we can capitalise really on the skills and experience of the people in those groups. I will pause there. I'm happy to take any comments or questions.
Meredith.
Thank you, John. Thank you very much, Claire. Very good. Just wanted to pick up on the move to Ptarmigan House very quickly. You said there were a few teething problems.
Yep.
Anything that we need to be aware of, in terms of significant dental requirements? But secondly, just to say, John, I wonder if it would be nice, I'd recommend, if you're okay with this, for the governing body to send a note to all staff and to thank them for all their, grit and determination to make it all work so well. But,
Absolutely.
I think that would be very much appreciated. Thanks, Meredith. I'll give you some examples of our teething problems. Don't get too excited. It's things like making sure that the post gets diverted and some of the telephones not working. So it's very, very practical issues that we've had workarounds for whilst we fix them. But certainly the significant things that board would need to hear about, there's none of those.
Well, until it's my call.
We'd always answer for you, Meredith.
Thank you.
Thank you, Meredith. Okay, thanks very much, Claire. So moving on to the minutes from the previous meetings, we have two sets of meetings. Firstly, those of the 12th of May. And just before that moment, within the chat, I noticed we'd received additional apologies from Mary Lasamney, and also that Adam Pringle's joining us a little later. So yeah, and then moving on to the minutes, those of the 12th of May. Has anyone any corrections, factual accuracy regarding the minutes for the first set of minutes of the 12th of May? Okay, I don't see any hand. Oh, yep, hands are rising. Excellent, a plethora of hands. Great, starting with Laura. Laura Clare. I think you might be on mute.
John.
Hi.
Sorry, couldn't get my mute button off quick enough. Yeah, I'd just like to highlight paragraph 12.4. It states in there, I think there's a few issues with the numbers that are being quoted on there. So first of all, it says in October we had a £50 million deficit. It should say in October we forecast a £15 million deficit, and subsequently broke even for Shropshire and a little of an overspend for Telford. It also then says further along in that paragraph, Mr. Braden wished to highlight the hard work that has been carried out by the execs, Mrs. Skidmore and Mrs. Clare, to take us from that position in October to achieve 71 million of QIP savings. I would love to report that we achieved 71 million of QIP savings, but it was actually 6.7 million. So if we can amend that, please. Thank you.
Yes, duly noted. I had picked up on 12.4 as well, having slightly impressive figures. Thank you for that, Laura. I think we can agree to amend that accordingly.
Thank you.
Thank you. And Julie.
Thanks, John. On page 5 of the minutes, page 17 of the integrated pack, it's just, again, I just think it's because it's been done from a recording. It's just to correct IAPT. So where we've got IAPS, it just needs to be IAPT throughout on there.
Thank you, Julie. I think that arises in several points of both minutes and agenda.
It does.
So there is not a new acronym, fortunately. It's all IAPT.
Many acronyms. We don't need any more.
Absolutely. Thank you, Julie. Mike.
Hi. Paragraph 7.2, matters arising log. I think I know what this is about, but I'm not really clear that it comes across as though it makes any sense. So it's up to you if you want to keep it or delete it.
Thank you, Mike. I think I'll come back. No, Mike, thank you. I'll come back to this when we look at the action log, because there's further to be said on that point. So thank you. Yeah, 9.3. Much as I would love a 2-minute wait, I don't think that's probably correct either. No. That's the cancer weights. Yeah, so that should read week. Thank you, Mike. Super. And Julie, did you want to come back?
No, sorry, that's a lazy hand. Apologies.
So I just had 11.11 to add, and I think the final sentence should say on the quality of respect forms rather than an and there, which reads a little bit more clearly. Good. Okay.
John, if I may, I'd got one more as well, please.
Yes, indeed.
18.3, where we're talking about the H1 finance position.
Yes.
Near the end of the paragraph, as part of how it's captured what I was describing, it said we would like to assure members not agreeing to take on the 6 million for CCG that this is a place to park the position. I think we need to just reword that, potentially part of the paragraph. All I was trying to explain at that point was that we'd produced a CCG position as we've described. The totality of our system position was reporting a potential £6 million deficit, but that risk had to be built into the position somewhere. So I'd agreed that would sit with the CCG. I was trying to make the point that wasn't the CCG taking on the system problem. It was just a way to report it whilst we collectively work through it. So I just wanted to make sure that was very clear. Yeah.
So we'll capture that and record those in these minutes today as well for clarity. Thank you, Claire. Mike. Historical hand?
Historical hand, mate. Thank you.
Thanks very much. Good. Okay, all those with historical hands could lower them. That's wonderful. Excellent. And then minutes of the 9th of June. Any comments for that set of minutes? That's from the extraordinary governing body meeting from the 9th of June. Claire.
Apologies, I'm scrolling very fast to try and find where I've highlighted, but I've got a list. In sections 3.2 and 3.3, there are references to the internal auditor. It's our external auditor that does our audit. They're external for a reason. They have to be independent.
Yeah.
In 3.2 as well, it talks about Mr. Braden assured members that the issues outstanding were not material. Assurance had been received from the external auditor that this would not affect the decision. It's not a decision that's impacted, it's the opinion that they produce. It's something slightly different. So decision substitute for opinion.
Yeah.
Then I've got a list. 3.5 talks about some of the conversation we had around improving efficiency in the system, which was a really good capture of that conversation. It then links to that, the suggestion that we invite the external audit lead back to the executive team around findings. I think that was a broader conversation, actually. We wanted to invite their quality lead back to governing body, specifically to talk about the work that they'd done to review our quality work. So I know that's arranged for one of our informal sessions next month, I think. So that's that one.
Yeah.
Two more. 3.6, I suggest we delete that paragraph. It falls out of context because we don't have a similar item around what was said for the Shropshire report. It doesn't take anything away from the minutes. It's stating something that's written into the report. So I can't see a problem in just deleting that one so that it doesn't disrupt the flow of the minute. And then 3.8, again, it was just a point of clarification around what we've already talked about for what was required around the final sign-off. So just to be clear, the annual report, accounts and associated documents were not changed. They were signed off at that board meeting. The only thing we took outside of that meeting was to do a final agreement of the audit findings report because the auditors wanted to finalise their work.
Yeah, thank you, Claire.
Sorry to be a pedant, but it's really important we capture these things correctly.
And if 3.6 is in the report, I think that's reasonable to remove as you suggested. And 3.8, we need to capture those accuracies within the minutes today to correct that. Thank you. Good. Super. Moving on then to the action tracker, and really going back slightly to Mike's point that he raised quite correctly. We today have an action tracker with 18 actions that I will have to inquire of, at least. Helpfully, Alison Smith has provided comments and recommendations against all of hers, and I think going forward, I think the item from May was certainly that we would like to see that in future, really, within the action tracker.
Yeah.
For all actions, which will make the meeting smoother, but also more informative to those preparing and attending and observing. So if we go through these to begin with, the first item on page 1 of the action tracker was regarding a question that Dr. Matty had raised regarding paediatric 14-day rule referrals. And Mike, have you had any contact with David Whiting to update on that or not?
No, unfortunately I haven't. Perhaps I should take it out with Julie. David's outside the meeting.
Yeah, can I come in? Because in fairness to poor David, he has been trying, Mike. And I was going to say there's an action on me to pick up with Mike about the performance report, which I hold my hands up. I've not had time to schedule, but I've asked Sonia to get me some time with Mike. I'm going to suggest I do the same thing, link David into that meeting so we can close both actions at the same time, if that's acceptable.
Perfect.
Oh, that'd be superb. Do we need, right, well, because I was liaising with Dr. Cowley, so I don't know whether we need to talk to him as well, but I think this can, if that's the way it's forward, that will be absolutely superb. Thank you.
Thank you.
Will do. Thanks, Mike.
That's super. And then we will close that. Super. And then moving on to the second point, which again was Mike was awaiting a response from MPFT with regarding a letter that he had written. I think Steve was facilitating the follow-up of that. Is that outstanding or can that be closed?
We haven't had a letter, but I think there are ongoing issues which I think a lot of other people are involved with. It is disappointing that we haven't had a letter, but as far as I feel that it's no point keeping it on. You might as well move. It might as well be closed and then move on to other people doing stuff for it.
Well, if we could just, if you could, it's okay to close it if we just have that assurance that you follow that up with Steve potentially, and if you have any issues that are outstanding as a result of that, then come back to us. All right. Yeah,
that's brilliant. Again, thank you.
Super. And then next item we've got is regarding what was for Senior Young. We've got a paper containing that today in today's agenda. The next question on page 2 regarding neurology services update. Julie, I was just wondering when that was planned, really.
Yep, as I say, we again, I can assure we're still having our fortnightly meetings with the trust, and I can assure governing body members that the new service is bedding in well. We're getting we've had no issues in terms of any complaints or any issues from patients. Some positive feedback from some of the patient groups, but it's too early to say. So I was going to say I think we did say I'd bring a formal report at 6 months, but I'd just give an update this month. But as I say, so far so good. The patients are, obviously really welcoming the service, as are I think the clinicians. So far so good. I hope it continues.
Thank you, Julie. So for that, we will take an action that will bring it back in November, which will be 6 months from the May date, for a further update. Thank you very much, Julie.
Thank you.
And performance, you covered that with your earlier question, with your earlier response. Thanks, Julie, to Mike. There's then a question on IAPT, which is in today's agenda. The third part of the performance report, it was just whether the subject of viral respiratory infections in children had been raised with the urgent and emergency operational group, Julie.
It's all been superseded by a big piece of work that the systems worked on with the RSV plan, so it's all been picked up through that, John.
Thank you, and that can be closed. Thank you. Next item is the maternity dashboard, which is referenced and covered within an item of today's agenda. And then again on page 2, for the quality report, I presume that the niche actions update, Zena's not here to answer, but I would expect that today would be slightly early for that to have come back. And are we in agreement to ask that be raised in September? Okay, thanks, Claire. If we could feedback that to Zena, that would be good. Thank you. Lynn, I think you put something in the chat as to whether the end of life group and Dr. Shepherd had been updated with the Health Watch report.
Yeah, I've shared the 2 end of life reports with Zena, but I also shared some comments around diabetes at SAF as well.
Okay. Thank you. Thanks very much. And Mike?
Just slightly disappointed for the niche report that we didn't have some sort of interim statement. That's all. But if it takes longer, then fine. But we did ask for an interim statement.
Yes, I don't know if there's anyone that can come back to Mike.
Tracy might want to comment on that one.
Thank you.
Thank you, Chair. Afternoon to everyone. For those of you who don't know me, I'm Tracy Sater, Assistant Director of Quality, and I'm standing in for Zena today. So the progress that we've made so far is that we have asked all of our providers to look at the recommendations on their behalf. We're in the process of collating those currently within the CCG, and they will be fed into the Learning from Deaths group that Dr. Shepherd is chairing. And the first meeting for that is on the 27th of July. So a couple of weeks' time. So we will definitely have a fuller update in September.
Thank you, Tracy. That's very helpful. Thank you. Okay. On page 3, the first box containing three actions recommended for closure. Unless anyone has any questions regarding those, Alison's given us comments, but she's not with us here today. And then the item regarding the LMNS, again, has been added into the cycle of business and recommended that the action be closed. So the final item on page 3, again, this was a request from Dr. Shepherd that the new website be reviewed with regards to medicines management and policies. Again, Zena's not present today. I don't know if anyone has an update of that. That does need to remain active because that does need to be sorted out. Anyone able to answer on that from the executive side? If not, I'd suggest that be fed back, if possible, please, to Zena in the interim, and then be brought back to our next meeting. Okay, thank you. Page 4, the commissioning strategy, 2 items for Sam Tilley to update. Sam isn't with us today. I think this was references to be made with the commissioning strategy. Oh, you are here, Sam. Marvellous. Apologies. Great.
I could have just kept quiet then, couldn't I? But I didn't think that was the right thing to do.
Good.
So
Good to see.
Just to briefly update on those. So I think obviously everything is moving at pace at the moment, isn't it? Particularly as we're now sort of getting some clarity in terms of timetables around ICS, etc. So I think we are mindful that as we've had these discussions about the commissioning strategy, the world is now moving on, and we're looking at how we now develop our set of documents in relation to the ICS and start to bring things together, particularly also mindful of not doing things more than the necessary times we need to do it. So those points will be carried forward into the work we do in terms of developing our key documentation in relation to the ICS. So points noted. that feedback won't be lost, and we'll weave that into the iteration that comes next.
Thank you. If we can close those actions then on that basis, that's great. Thank you, Sam. Then Alison has recommended closure of the following item. The item with regards to the audit, as Claire's referenced in the accountable officer's report, has been closed and actioned and closed. And so finally, further items regarding Mrs. Young, which was with regards to, yes, this was an item regarding learning disability and a question with regarding IQ measurement in primary care, which Rachel had raised. Rachel, I'm not sure whether you have any update there, whether you had any communication with Zena on that at all.
No, I haven't had any further information.
Okay, so another item to be fed back, please, and continued. Right, and then also, I think the next item will also take back to Zena, which was with regard to the appropriate completion of respect forms for patients with learning disability, and not the automatic use of DNA CPR forms. Final item of the tracker. Claire, any update from you on that item, please?
It's on the agenda, John, for the next LDNA board.
Excellent. Thank you very much. Good. So hopefully in 2 months' time, we will see the action tracker in a slightly different format, please. Thank you. Meredith.
Thank you. It is understood that our executive colleagues are under extreme pressure and lots of work needs to be done against tight deadlines. And I'm just wondering whether some of the actions that we as non-executives might ask for information on, we could be a bit more proactive, and rather than waiting to hear from one of the executives, we actually just pick up the phone and say, is there any update or anything I can do to facilitate further development or something like that, just to make sure we keep things progressing?
Yes, and on that front, I propose that the owner of the actions are both the person who is providing the response and that person asking the question, so that there's an understood shared ownership. If anyone disagrees with that, by all means, pipe up now. Otherwise, that's what we're doing. Okay.
Thank you.
Good. Right. Questions arising from members of the public. I've not been informed of any additional questions for this month. So moving through into the agenda, we start with a maternity services update. I think Fiona, you're talking to us today in Zena's absence, which is great. Thank you very much. If you'd like to just briefly introduce a brief summary of the paper, Fiona, because I think obviously the discussion around this is of importance, but thank you.
Thank you. For those of you who don't know me, I'm Fiona Ellis, and I'm the Programme Manager for the local maternity and neonatal system across Shropshire, Telford and Wrekin, presenting the reports today on behalf of Zena Young. So just to give you a quick snapshot of the key headlines, really, there is lots of progress that's being made within maternity services locally, both in terms of quality and safety, improving experience, but also in relation to transformation, the transformation activities that we're looking to progress. So we are making steady progress against all of those things. But we're continuing to be challenged by instability in the workforce within maternity services, particularly in relation to the senior midwifery leadership, which is causing significant challenge for us and driving the agenda forward. We do still have issues around data quality, which we are working to resolve, but it's not a quick fix. And the implementation of Badgernet, the new maternity data system, is key to that, but that is experiencing delays, so is hindering further. Continuity of carer is not where we would like it to be. So this is where women receive their midwifery care from the same small team of midwives. But actually, we're not out of line with other areas. Everybody is struggling with this. So I think whilst the numbers don't match what the national targets wanted, where we were needed to be against national targets, actually a lot of other areas are in the same position as us, so it's not of great concern. Smoking in pregnancy is a key priority for us, and we're implementing a new service model which is in line with good practice, and really will start to see a significant improvement and reduction in relation to the smoking in pregnancy rates. But as a system, we need to find the money to support that service ongoing. So through the long-term plan, some money has come down to the system, but for this year, it's part year effect at only 40% of the full allocation. So we're hoping that in a few years' time, we will see much closer to the amount we need coming down in relation to the long-term plan. But as a system, we need to make sure that we have secured funding to continue with that service, because it does have a significant positive impact on outcomes for women and their families moving forward. That was all I wanted to highlight, really, John. So really happy to welcome discussion and questions in relation to the paper.
Thank you very much, Fiona. Any questions for Fiona? Audrey?
Sorry, couldn't unmute. Thank you, Fiona. Great paper, very thorough, and obviously you can see the progress, which is really fantastic. And also, best may I congratulate you on, despite the struggles with some of the staffing, you've got 100%, almost 100% one-to-one care and labour, which is a brilliant achievement. Just a few questions from me. We didn't see the perinatal mortality rate, which is your stillbirth and neonatal death rate, obviously a combination. Is that because it meets national guidance, national targets, and therefore that's why it's not in the report, or are there other reasons?
We can certainly provide those figures for you, Audrey, and certainly the figures that we have seen through CQRM, the Contract Quality Review meeting, which looks at the quality of services. We're seeing a reassuring downward trend in the number of stillbirths, neonatal deaths, and indeed brain injury. And through the implementation of the Saving Babies' Lives Care Bundle, which is referenced in the report, we hope to see those reduce further. Yeah. Audrey, there is linkages back though to the data quality issues that we've got and the timeliness of reporting from the trust, and it is something that I'm working closely with the trust on through the local maternity and neonatal system, where we're looking at a system-wide dashboard to make sure that we've not only got the data coming from within the trust, but we're able to benchmark that against our comparator CCGs, comparator trusts and national indicators to make sure that we are in line with where we need to be. And the next step as part of that process is also to include feedback from our Maternity Voices partnership along with that, which is relevant for some indicators more than others in terms of actually, does the experience of women and families, what does that tell us about the numbers? Because actually the numbers could look really positive from our point of view, but actually if women's experience is saying the opposite, then that will then have cause for concern. So partly data quality issues, Audrey, but certainly in terms of the numbers we have seen, we are assured that those are steadily reducing, which is really positive.
That'd be great, and it'd be great to see it in future benchmarks nationally. Fantastic. Bookings, just talk about bookings for a moment. You've reached 85% of booking women before 13 weeks. Do you think there's a particular group of women that you are not reaching, or is it broad spectrum?
We're looking into that. So through the new system-wide dashboard that I referenced, we're able to break down data down to people's ethnic origins, so particularly looking at Black, Asian and minority ethnic populations, as well as those living in social deprivation. What we're also able to do is interrogate that data based on primary care network. Okay. So as a local maternity and neonatal system, what we are able to do then with that data is target our services accordingly, and initiatives like continuity of care are key to that. So we know that by rolling out the continuity of care teams in those areas that have got the highest proportions of Black, Asian and minority ethnic women or social deprivation, or those areas that we know are have other factors which could contribute to negative outcomes, that we roll the teams out in those areas so that we have a positive impact for those groups. So at the minute, Audrey, it's not clear, but we're looking into that through the data that we're collecting.
Okay, that's great. And of those 15% of women not booked before 13 weeks, are you aware of any incidents where perhaps their screening did not happen, particularly around scanning and bloods?
Yeah, not to my knowledge. Our screening data is quite positive.
Okay, that's lovely. 2 more questions and that's it from me. The induction rate is 40%. Okay, that's quite high. It's above the national average. Do you know what's driving that? Is it age? Is it obesity? Is it twins? You know, have we got some indication of what is driving that quite high induction rate?
It's a mixture of factors. So some of it is actually in relation to national policy. So through the Saving Babies Lives Care Bundle and the drive to reduce stillbirth, actually what that meant was then that many babies were being induced earlier, and therefore the induction of rates, when induction of labour rates increased. The Saving Babies Lives Care Bundle has now been adjusted to account for that, to hopefully bring us back down. My understanding is that nationally, induction of labour rates are increasing, but you rightly acknowledge that actually the complexity of women is changing, and therefore that has an impact on lots of different aspects of service delivery. And that's why it's really important for us as a system to not just look at what's happening here, but look at what's happening elsewhere in areas that are similar to us and other areas where they've got recognised good practice, so that we can learn and make sure that we're not out of line. The other thing that's really important, Audrey, is to not just look at induction of labour, for example, in isolation, but to look at the related outcome impact.
I completely agree with you all there, but I still think it'd be interesting to see what is driving that rate. I mean, I completely agree. Outcomes are everything, but it would be good to see what's driving that high rate. Yeah. And my very last question, you'll be very glad. Training it's one of the CNST standards, and I'm interested because of the SIs over the last 4 or 5 months. Do we know how many staff in the maternity obstetric unit have been trained this year on their CTG interpretation and emergency skill drills?
Yes, we do, Audrey. I haven't got those figures to hand, sadly, but I can happily send those on. So each clinical quality review meeting, we have a workforce report, and in there is the training data. So I can certainly get that for you and pass it on.
That's brilliant. Thank you ever so much.
Thank you, Audrey. That's really, really helpful, and for your responses. Fiona, just briefly, if I could just interject on the induction of labour figures. I noticed there was a mention that possibly our figures may be different to national figures because of them including inductions for terminations of pregnancy. Is that still the case, or is that resolved?
No, I think I'm not sure in terms of the definitions, and I think we can measure it in a different way. But I think it's a really valuable point, John, in making sure that we are comparing like with like, because it won't just be that indicator that's happening with necessarily. And I think it's really important that as different things are measured for different purposes or to different reporting routes, that we're clear actually what is the definition behind this indicator. Are we comparing like with like? Because you're right, that is for induction of labour specifically, and our local collection of data, that was a specific consideration.
Okay, thanks. And it'd be great to see that sort of enhanced data coming back to us that Audrey's alluded to. So thank you. Jeff.
Yeah, thanks, Chair. It was just a question really around the serious incidents. I noted that there's still an outstanding action point in terms of bringing the transparency to public for serious incidents. It's going to happen in August. But I really just wondered, obviously because by definition they are serious, how confident we are now that the RCAs are getting closed off in a timely manner, but we're also going back much longer than 5 months to really make sure that some of those RCAs that we've closed hitherto have stayed closed.
Thanks, Jeff. I don't think I'm best placed to answer that question because I'm not as close to it. I wonder whether Tracy, in Zena's absence, if you're any closer to that. Thank you.
Yes, thank you, Fiona. Jeff, I can actually say that with confidence that within the CCG we monitor the flow of all the SIs, the RCAs. We have tracking through the CSU. And one of the things that I'm currently doing at the moment is looking at a methodology for a look back, exactly what you've just said, sort of once those incidents are closed, a look back exercise to establish sustainability and of those actions that have been implemented within that process.
Lovely, thank you.
Thanks, Tracy. And Julie.
Thanks, John. Fiona, it was just a question about the delay in Badger Net. Do we know how long it's been delayed by?
They're starting implementation from next month, Julia. They're now going through a phased implementation. So starting, my understanding, with the antenatal phase, which is starting in August, and then rolling that out on a phased basis from there. And I think there are challenges, I think, in terms of making sure that the workforce are trained accordingly in order to make sure that the rollout is successful. So the starting soon, but it will be a phased implementation over a number of months, is my understanding.
Good, because it just felt, obviously, doing the whole pressure around the manual recording of data will also add another pressure on staff, won't it? So it's kind of chicken and egg, really, isn't it? We kind of have to hopefully implement the new system, and that'll start to take the pressure off, even though, as you say, because of the staff, it will be done on a rolling basis. But that's good news. Thank you.
Thanks, Julie. And Steve.
Yeah, thank you, Fiona. Couple of points. One, it's great to see the investment in trauma-informed approaches and care, which hopefully will spread from that small seed across all the services and more broadly across the ICS. There's a little line in there that talks about smoking, and we need to work together as partners to sort out the smoking. What would your take-home message be to us in that space? What do we need to do? What do we need to unblock?
Specifically for the smoking and pregnancy service, it's money. So we managed to, through system commissioners, get enough money to commission a service that's in line with good practice this year, with the anticipation that money would be coming down from the long-term plan to support the ongoing delivery of that service. The money we've had this year and the money we anticipate getting next year are way off what we need to run the service. So it's just about actually mapping that out in terms of the system's commitment to that, because this isn't just about smoking and pregnancy. If we can have smoke-free households for those babies to be born in smoke-free households, that then is a generational change in terms of smoking. So I think it's really important, because this isn't just about pregnancy outcomes. This is about lifelong outcomes for that family. So I think it's really important that as a system we commit to that ongoing funding for that service.
Thanks, Phil.
Thanks, Steve. I recognise a couple of hands up. Martin, I think yours came up and went down. I presume possibly aligning to the smoking question.
No, it wasn't actually. If I might, I guess two things. I have heard the same comment that Badger Net is coming, and over several weeks. So I guess it would be nice to almost have some sort of a Gantt chart when that is going to be phased into the different practices, because it seems like it's going to happen sometime, but I just don't quite know when. But the question I was going to come back to Tracy about the Never events, which caused me a little concern. And I guess it's great that we can review any events that have happened previously. I guess, will we look, Tracy, at effectively auditing their interventions that they've made? So if they've operated on the wrong limb, for example, will we then say, OK, they've now got the WHO chart in place and they're utilising it? So I think it's not only checking if they have not had another event, but have they put the processes in place to ensure that doesn't happen again? And are we auditing that? Because they may put the process in place for 6 months and then forget about it, and then 2 years down the line we have the same Never event.
Tracy, do you want to answer that now or when we come on to the quality and performance report in which these are referenced?
Yeah, either. I'm happy to, I mean, talk just briefly about Never events and assurance processes, just briefly. So you're absolutely right. It is very much about triangulating what we hear and is reported at CQRM. We also, as a quality team, now go out, have been going back out and doing face-to-face visits. So we've got our own sort of quality assurance metrics, and we don't, if we when we come to close an SI or a Never event, we actually, even though we might close it, we continue to monitor any actions that aren't closed, and auditing of those actions again come through CQRM.
Yeah, if I may, John, I think that's great that we audit it. It's actually making certain that the changes the organisation put in place are maintained, because the last thing we want is another same never event 6-12 months down the line, because they've gone back to their good old ways.
If I may add to that, Tracy, the other thing we're looking at, Martin, is in relation to themes of SI. So I think through CQRM and
I think we lost you there for a bit, Fiona. Fiona, we lost you.
Sorry.
We lost you after the point where you mentioned looking at themes.
Yeah, so I think that will help to address any concerns early if we think that we're going back to something that we'd identified previously.
Thank you both.
Thanks. I was going to bring in, or it may be unfair, to ask Rachel or Liz whether they wanted to comment on the earlier points regarding smoking in pregnancy and how we approach this as a system. But if you'd like to come in at this point, do. But apologies if I'm putting you on the spot.
Hi, John. I'm happy to make a comment. I mean, I think it's fair to say it's taken us quite a long time to get to this point. I think 2 years ago we recognised it's a big challenge for our system, one of our key priorities for the reasons that are outlined in the paper, and we've worked really hard to get to the point we've got now, reviewing the best practice, reviewing the evidence, wanting to have that system approach. I think we are disappointed in the settlement from the long-term plan. We obviously recognise the wider implications in terms of the system. I know Telford have got a different offer in place in terms of that wider service to Shropshire, and we recognise that from a Shropshire perspective in terms of what we needed to do going forward and linking that up. But I think there is also a pushback to the wider system. It's taken us a long time to come to this point. We continue to fund the service this year, even with the recommendations that we'd get funded through the long-term plan because of our commitment to it. So we remain committed to the service and having a combined service, it being a best practice model. And I do think this is where, as Fiona said, as a system, we need to look at the response and kind of not just moving things around, but how we look to invest in that collectively. So there's still some work to do, remain committed to doing that. But and it's taken us a long time to get to this point, but also recognise that we've got wider investment that we need to make in that wider system outside of just the maternity element in the kind of wider community. And that as a council, our public health team within Shropshire I commit to, and I know Liz, they're in a slightly different place in Telford because there's different services there. But I think I just wanted to make it clear to the board that remain committed to this and as a priority, and we've worked a long way to come to this point, and we are disappointed with that settlement in terms of delivering that best practice model.
Okay, thanks very much, Rachel. Liz, did you want to add?
I think Rachel's probably said all that I was going to say. We do have our own smoking cessation service for the general population, but clearly pregnant women are a key priority that as a system we do need to commit to. But I don't know the details of the shortfall, so in a sense I can't comment particularly on the details and wouldn't want to do so here, but happy to have the conversation outside of the board.
Thanks, Liz. And Meredith.
Yeah, thank you very much, John. Thank you, Fiona, for an excellent paper, very, very informative, and conversation around smoking cessation reminded me that one of the benefits to be derived from the Transforming Midwifery Care program was the creation of maternity hubs where amongst other things, smoking cessation support might be offered. And then it reminded me, we haven't heard anything for a long time about where we are in terms of getting support to go ahead with the consultation. Are you in a position to bring us up to date with latest developments?
Indeed, I can try, but I think it's probably the same answer that we've been given for several months, which sadly is that we're still awaiting national approval to be able to go out to consultation. We are in contact with the national team around that and have been recently asked to check whether what we're proposing still stands, and it does, and is still relevant in light of other initiatives or reviews that have happened since, for example, the Ockenden review. And we're also asking external colleagues to have a look at what we're proposing to get that external viewpoint as well in terms of, is this the right thing to do? The maternity hubs are a key solution to many of our workforce challenges, multidisciplinary training requirements, you know, the public health initiatives as you've highlighted, Meredith. And I think what we need to do is to make sure that the inequity that we identified as part of that review is addressed in some way, because it sits really uncomfortably with me that we identified, you know, health inequalities as part of that review, and we had solutions to address those health inequalities and haven't yet been able to mobilise those solutions, and that isn't right. So I think it's just about how can we seek to address those health inequalities whilst we await the approval to go out to consultation.
Yeah, it's just unfortunate that some of the short-term solutions may not be aligned to the longer-term approach. So it's a tricky balance. But anyway, thank you for that. That's great.
Thanks, Meredith. And finally, Mike.
Thank you. Smoking remains this horrible paradox when it's in the 5-year plan, but no one actually will give us any money. So it still remains an ongoing issue which we've discussed over the years. Badgernet, I've talked to the local midwives who say it is ongoing, but it's because of commitments like the rest of us. I think they're struggling to get people time to actually involve it. The only thing about like Badgernet, I think about those smart meters. They may well sound good, but unless you actually cut and actually use them properly and actually do something with them, it's not going to change the world. So it's one of those ones where not just having the system, but actually implementing it, and it actually shows to be beneficial is the only way that it'll work. On its own, it's just a name.
So thank you, Mike. Fiona, I don't know if you just want to come back on the benefits of Badgernet, really.
Yeah, I support that, Mike, and I think that's why the slower rollout that is now proposed by SAF, I think, is better, because it will enable them to do exactly what you've described in terms of making sure that it's rolled out in a meaningful way, that everybody understands and that everybody's using the new system to maximum effect. I think we have been told by the provider that Badgernet will help to resolve many of our issues around data quality, information sharing, and electronic patient records and the like. So I think there's a lot held on implementation of Badgernet, and I can see the theory of how much better it's going to be. But as you rightly acknowledge, actually we need to make sure it's rolled out in a sensible way for it to enable that to happen.
Thank you, Fiona. So the Governing Board are invited to receive the update report, note and discuss the contents of the report and progress being made, note the areas of concern and the actions being taken to address them, and also to note that a funding model for smoking cessation, which could encompass wider health education, needs to be developed and agreed. Okay. Thank you very much, Fiona.
Thank you.
So moving on to the in the agenda, it's marked as the Restoration and Recovery Update Report. I think the paper is titled the Elective Recovery Report, firstly from April and May, before we then move on to the Quality and Performance Report. So, Julie, I don't know if you wish to just give us a very brief outline to this, and then we can open it to discussion. Thank you.
Yeah, this is just obviously keep the governing body informed of our progress against our elective recovery plan for the first 2 months of this financial year. Since I wrote the paper, we are still waiting for the feedback from the regional team regarding our submission for May. I was hoping that we might have had it in time for me to be able to verbally update the board, but we haven't. And then just a further development, we have received some additional national guidance. It was published on Friday that has now increased the activity thresholds from July from 85% to 95%. As you can imagine, that is going to prove somewhat of a challenge, and the system is working through the consequences of that new guidance, what that means, and the associated risks associated with that. And we'll obviously be taking through that through the appropriate channels over the coming days and weeks. But apart from that, happy to take any questions.
Thanks, Julie. So that's any questions, Julie, regarding the elective recovery report. Otherwise, we would move on through to the quality and performance report. Okay, thank you. So the governing body is asked to note the content of the report at this early stage, to receive partial assurance regarding the Shropshire Telford and Wrekin systems delivery of its H1 elective recovery plan. Thank you. So moving into the quality and performance report, Julie, do you want to introduce, and then we'll open to discussion?
I will. If it's okay, what I'll do is I'll introduce and comment on the performance section, then hand over to Tracy for the quality. Then we'll both open to questions and discussion. Thank you. Again, just wanted to bring to the governing body attention, this is the first time we've been able to report in a programme in our new reporting format for making data count. So happy to take any feedback from the governing body on that for future reports. And then also to update, I think last time we noted, because this was our first time as reporting as a single CCG, we did have a lack of historic comparative data. I'm pleased to say that my team were ahead of me on that one, and they are all working on those proxy measures to give us some degree of comparator retrospectively, and those will be available in the September report. So that was all I was going to pick up onto the performance section, and happy to hand over to Tracy for the performance, any performance quality comments.
Perfect, thank you, Julie. Tracy.
Thank you, Julie. So if I can just highlight a few areas, just pull a few areas out of the report. So firstly, following a fall at Sath and the unfortunate subsequent death then of a patient, Sath have been served with a HM Coroner's Regulation 28 report. And this was around the teletracking, the portrait notification system, whereby insufficient information was recorded. Just to, as previously reported to governing body, the work in relation to the CQC section 31 condition for children and young people, that work continues to take place across the system, looking to find solutions and future options for our children and young people. Thirdly, as you can see from the report, just touched on it earlier, there were two wrong site surgery never events reported by Robert Jones and Agnes Hunt in April. Both of these related to regional block. The investigation is underway for those, and full reports will be received into the CC during July. But I can provide some assurance since this report that myself and another member of the quality team have visited Robert Jones, and we are assured of the remedial and immediate actions that the trust have implemented around the inconsistent level of the WHO process and their audit method. And finally, just the MPFT suicide report that you'll see in the report. The CCG have raised some concerns around the interpretation of data and conclusions, and that is with the trust to come back through the governance process of CQRM during September. But happy to take any questions.
Thank you, Tracy. So open to discussion and questions. Audrey. You're on mute.
Thank you both. Thank you, Tracy and Julie. Quick question around falls. Would it be a good idea perhaps next month or the next board meeting we spent some time looking at falls, particularly around what has happened since the coroner became involved, and that way we can see the trajectory, we can see the work done, we can see the improvement work. I think if you're both in agreement, it might be a good thing to do. And secondly, the two Never events at Robert Jones, one of the members of staff came from Sath. I presume the learning has gone back to Sath as well. I'm sure that's happened. Yeah.
It has, Audrey, and what's happened is it's a joint investigation, though it's been attributed to Robert Jones. Sath are supporting Robert Jones with that SI.
Lovely, thank you very much.
Thank you. And in terms of Audrey's, suggestion of coming back with a fuller look at falls and how, how the incidents are investigated and learnt from, and changes that are made.
Happy to do that.
We can either take it to the governing body, or I know Meredith's just put his hand up, but is that something that it might be more appropriate to take the detail of that, sort of like a deep dive through the Quality and Performance Committee, and then through that report the headlines to governing body, if that would be appropriate?
Meredith?
I was going to suggest that, yeah, just to give us more time to get into the detail at the QPC.
Good, that's excellent. Thank you both. That's good to progress that. Thank you. And Donna?
Yeah, just a couple of questions from my perspective in terms of the detail of the report. One was around the pressure ulcers, where it talks about them being equipment related, and for an individual such as myself, trying to understand exactly what that meant, and again whether we've got appropriate training or appropriate measures have been taken to address that. So that was one around specifically around pressure ulcers, and the other one was under the section about the harm reviews, where I can see that for the 12-hour breaches, that there's been a suggestion of auditing kind of 10 and then 10% beyond that, and I just wanted to understand where that came from, and are we assured that we're capturing all that we need to, and we're making sure that harm has been minimised by adopting that approach.
Happy to take that. So, Donna, with regards to the pressure ulcers, that was Robert Jones that had seen an increase in category 2 pressure ulcers. I think it was just a small increase. They had seen some issues with equipment, which we're confident that they've addressed that. And they've also now had a new tissue viability specialist nurse that started in the trust that's supporting training across Robert Jones. Okay. The second second question about the harm reviews, we ask for 10 and then 10%. You're quite right. That's within a 24-hour period. So that was agreed with the CCG, and that was there's enough information that comes through the 10 plus the 10% to get any themes or any issues that are addressed that then come directly through to that we can pick up through the clinical quality review meeting.
Does that answer your question there, Donna, with the 10 and 10%?
Yeah. I was hoping that we were really not going to have such significant numbers in a 24-hour period that we couldn't have conducted all of them anyway. But I just want to feel that we aren't missing any harm to individual patients on the back of only doing a small amount or a smaller amount, it appears, of those reviews. But I'm hearing from Tracy, I think that she feels that we would be suitably assured and get that assurance from that. But that's where my question was coming from.
And I think it's worth saying that we don't see harm coming through for patients within those pro formas. I think that's some assurance that I can provide you with.
Thank you.
Thanks, Donna. And Mike.
Thank you. 3 quick things. Firstly, I welcome the bit about the suicide, because that was the content of our letter and concerns that were raised about people and the management of people who were attempting suicide and were we felt poorly managed. So if that's going to carry on and looking into those things, then I'm quite happy for our letter meeting. But that was the basis. So I'm very pleased that is going ahead. Secondly, Ulysses, I think, talk about Ulysses, there still remains quite doubts regarding general practice that anyone does anything about Ulysses reports. People still remain very sceptical, and hence I think that once again it's how you persuade people to use it. And I have to admit that I struggled to do it, because last time I wrote to someone, which was 6 months ago, I'm still waiting an answer. So therefore it's trying to make sure that the system is robust and works and we do get timely answers. And the third one, which is really quick, is you're talking about mental health and LD care, and I didn't understand what IAPT access to psychological therapies meant when it says target 100%. I don't know what that is. Does that mean people actually being seen by IAPT, or just talking to someone from IAPT? Because we've had people who talk to IAPT, and then I've been told that they have to wait over 6 months to be seen. And some people are actually in counselling who are being moved to another counsellor, but again, I've been told that there is another 6 months wait. So what is it actually talking about?
Julie,
it's still the original target, which is about the access. So it is that contact, not actually when they receive their treatment. Right. We can argue till the cows come home. That unfortunately is the official metric. There is the metric behind that about actually being seen that we're working on. The new 100%, it is a new metric rather than in the past we've had a percentage. Now what they're saying is they work out a national expected proportion of the population that should be accessing IAPT, and if our numbers match that rate, then that in effect is it's an absolute number. We felt they're just quoting, and I must confess I can't remember the exact number off the top of my head, but you know, making a number up for effect. Say it was 600 people that's calculated as our target by NHSEI, then we've had that, you know, 600 Shropshire and Telford and Wrekin people have accessed the service. So that's where the 100% comes from, because the absolute number, with all due respect, is fairly meaningless. It's whether or not we are able to meet what's expected to be the demand for our population. So it is a new measure. It's been measured differently from April, so hence it is a little bit clunky, and we just felt that the percentage was probably more indicative for governing body members rather than an absolute number of patients, which wouldn't really mean anything.
Yeah. Is there any way we could find out? Sorry, John, I don't know if this is appropriate. Is there any way we can find out what the waiting times for IAPT actually are to be seen formally? Because I think that is,
yes, we can.
Most of the time it seems to be over the phone anyway, but I think that'd be interesting to know what the delays are, because it is all secondhand that I've been told, but some of the things I've been told are also quite scary. So yeah, that's, you know,
we'll look into that for you, Mike. Thank you.
That would be absolutely superb. Thank you very much for all 3 questions.
Thanks very much, Mike. And Jeff.
Yeah, thank you, Chair. It's just a general question really around safeguarding, particularly around the history that you know, we've had in Telford over safeguarding issues. And I struggled, I think, a little bit reading the paper to get a real feel for the number of children rising, which is clearly there, but where that was projected to go and whether we've got the capacity to do that adequately. Obviously, the concern of health assessments not taking place in Staffordshire, but also, I suppose, you know, it's been in the wider media around the lack of cases coming up because of face-to-face meetings through COVID for safeguarding children. And it's been such a critical issue for us as a health economy in the last 10 years ago. Yes. It just felt to me as if it needed more detail and some assurance, I suppose, that we were absolutely on top of this, and as a board that we were confident that we were on the front foot rather than waiting for a tsunami of cases as COVID was ease going forward. I don't think I've articulated that particularly well, but hopefully it's you've got the thing.
Well, you've cut out just slightly towards the end, but I think we caught the gist of that. Julie, did you want to respond? Notice your hands up, Julie. Is that?
Oh, sorry. No, it's a legacy.
Okay. Tracy. Thank you, Tracy.
Thank you, John. I'm happy, Jeff, to take that back to my safeguarding colleagues and discuss with them how we might be able to provide that greater detail and that level of assurance that you're requiring.
Thank you.
Thanks, Tracy.
Maybe, yeah, and if that can inform the future reports as we come back, that'd be good. Thank you. Meredith.
Thank you very much. Just picking up on that point, we do get quarterly reports on adult children and looked after children safeguarding at Quality and Performance Committee. So that information is all collected and presented. So Tracy, it may be that we can distill the key points for a governing body meeting to provide that overall assurance. John, I just wanted to pick up another point. At the last Quality Performance Committee, there was a significant discussion around backlog, exponentially growing backlog around individual commissioning and the significant capacity shortfall within the CCG. And I was a bit disappointed that that's not raised in this report. It may be that, well, anyway, yeah, I was a bit disappointed about that. I do know that some short-term funding has been found through the ICS process, but I think it's an important issue just to make sure the governing body is aware of overall.
I agree. Does anyone want to come back on the individual? Yes, Claire.
Probably as the director in charge of individual commissioning, it would probably be appropriate to make a comment at this point. I think we've always done separate reports to quality and performance around individual commissioning. As we have got the backlog, as we did with the hospital backlog, we probably ought to put the trajectory and our key milestones against the trajectory going forward. So I'm happy to do that. I mean, as you say, Meredith, on a positive spin, we have had our funding approved, and actually it was signed off by NHS yesterday. So I'd already kind of preempted that slightly and got the wheels in motion to get the staffing in there. But we'll certainly give updates against the trajectory going forward at governing body and certainly through Q&P.
Yeah, that's great, Claire. Thanks very much. Am I right in thinking it's just a short-term funding? Is it 2 months or something?
No, it's a significant amount of funding for longer than that.
Oh,
yeah,
great.
Yeah.
How long?
I can't remember the actual length of time, but it's
Claire, it covers the period of the backlog clearance, so the additional capacity was costed to the point where the team got everything back to manageable levels,
which I think is the autumn.
I think I was going to say it's autumn time, rings a bell, but yeah, I can't remember off the top of my head, but the important point is it's sufficient to get us back where we need to be.
Yeah, great, thank you very much, that's very good.
Thanks, Meredith. And just a reminder, I think that very happy for things to be in the chat, but the members of the public can't see the chat. And I know, yeah, Lynn's kindly added a comment that Shropshire Council assured the Health and Wellbeing Board that home visits taking place during the pandemic, and that's regarding with children's welfare and safeguarding. Thank you, Lynn. Okay, so I noticed that there are two papers actually together on the agenda here. The Quality Exception Report is really, as I would see it, Julie, it's a repetition of the information from page 8.
There was a slight error there, John. That didn't need to go.
So we can take these together, unless that anyone had any outstanding questions because of the split papers that they had been delaying on. Otherwise, I shall read the recommendations from both and take them together. So the governing body is asked to note, and I would say discuss, the contents of the reports, and that we receive the report as assurance that the CCG is discharging its statutory duty to secure continuous quality improvements in commission services with respect to quality assurance. Okay, thank you all. So we've now got a 10-minute break. We are probably about 5 to 10 minutes behind. But if we take a good, slightly shorter than 10 minutes, an 8-minute break or so, and then see you all back here. I'd suggest we turn microphones and cameras off, but we can keep the recording going, keep the streaming going if that's easier from a technical viewpoint, and I'll see you all back here in 8 minutes. paper. Laura, thank you for presenting this. If you want to introduce the finance paper briefly, and then we can open it to discussion. Thank you.
Thanks, John. Yeah, so I'll take the paper as read, but this is the month 2 finance report, so it's obviously very early in the year with fairly limited information at this point. We are being nationally assessed and formally reporting on just the H1 position, so the months 1 to 6 position. We are showing, in line with the system plan that was submitted, a £6 million deficit for the system at H1. But for the CCG itself, we've got a slight underperformance at month 2 and on plan for month 6. Locally, of course, what's important for us is that underlying position and what that looks like for our sustainability plan. And at the moment, we're reporting a £7.2 million gap against that, which is purely down to our progress against the efficiency target and that unidentified efficiency plan that is still in place, which Steve's team are putting a lot of actions in to address and improve in the future months. I think that's probably it, John, as a summary. Happy to take questions. Thank you.
Opening it to questions was great. Thanks very much, Laura. Okay. Julie, I'm assuming that might be a historical hand from welcoming yourself back to the meeting. Otherwise, I suppose if I can open with a question, Laura, it was just regarding the long-term financial plan. There's a in the penultimate paragraph, I mentioned that an initial view of the future year's position should be available for July for consideration across the system. Now, I know that's a system thing, and is that likely to come back here so that we see that long-term?
Yeah, so at the moment, the long-term plan's currently being developed for the meeting with Julie and Kelly, which is on the 22nd of July, I think. Claire will correct me if I'm wrong. So as soon as we've got something worked up for that, obviously that will go through internal governance processes and the finance committee and then to board, yeah.
Okay, thank you. I mean, clearly our focus is within the paper, certainly on the CCG element of this, quite rightly so. And Donna.
Yeah, just a couple of points. It was just around the quip that we've kind of identified or found. I think it says in the paper that the 6.2 million. Is that found and delivered, or found and we're hopefully going to achieve that during the year? So I suppose is that in the bag already? That's the first question. Yeah. And a very small little point, but it was around the unbudgeted agency spend against running costs, just to get a little bit more information about that, and is that something we're looking to address?
Okay, so first question then around the quick delivery. I think it's fair to say it isn't in the bag. There are some savings that have been delivered already year to date, which are contained within the paper. I think that's about £500,000 so far at month 2. There were some of those schemes that weren't due to start till later in the year, and we have previously flagged risk around that, particularly in individual commissioning. Claire Parker alluded earlier to the investment case that was put forward for additional staffing, which has now been approved. So that risk should start to come down, but until we start to see the delivery, I wouldn't be able to say that it's in the bag. No, sorry.
Is that just concern in relation to we've got a gap, and actually the gap may even be bigger than we think if we're suggesting we've got 6.2. So it's just keeping us appraised of where we are, I suppose, just to understand it.
Yeah. And a detailed report on efficiency delivery does also go to the finance committee every month from Steve's team and the PMO, but we will include it in the governing body update as well. Yeah.
Thank you.
In terms of running costs, so in year we have got non-recurrent pressures around some agency costs and some double payments for senior posts within the team. So we will be looking at that in terms of the recurrent cost pressure. So that's really where we're focused at the moment. So there is a permanent vacancy freeze in place at the moment. We are only approving permanent vacancies to go out on an exceptional basis. So yeah, so there's non-recurrent pressures this year, but recurrently is what we really need to focus on, Donna, in terms of how we're going to move forward into next year and address that kind of start point, really. Claire, did you want to comment?
Yeah, thank you.
Yeah, just to expand on your point, Laura. So there's two dimensions to the agency and interim staff piece. One is the grip and control piece, which Laura's described in terms of the vacancy freeze and making sure that we've got a thorough assessment of any post before it gets taken forward. I think the other is the context that we're operating in. So as we move towards the 31st of March and we're looking to define what an ICS looks like, there's little benefit in recruiting substantively into posts at the moment, so we have to think a little more carefully about the right thing to do for the next sort of 6 to 12 months. So that's not to say that we don't take a decision to recruit permanently, and certainly where we've got staff who are in roles that are patient facing, it's a slightly different consideration to some of the roles or the needs that we might have, where we've got other ways that we could cover it. So it's a fine line we're treading at the moment, Donna, because whilst we don't want to make lots of permanent recruitment whilst we're making changes to how we're structured and organised, we've got to find the people with the right skills to keep us going and do all the things that need to be done.
Thank you, very understandable. Thank you.
And Steve.
Yeah, just to expand on Laura's points, which was predominantly that we are in the process, following a very helpful meeting with Jeff, thank you Jeff, building up a much more rigorous 12-week plan rather than a 6-month plan, so that we've got clear sight on where we're up to with our efficiencies, and importantly, and as you can see in the paper, whilst we're tracking those, they are phased over the year. We're also being able to see on a month-by-month basis, reporting into the Finance Committee where the gap might be either closing, maintaining or growing. So we're very much aware of that as a team.
Thank you, Steve. Yeah, I think that's a really helpful piece of work, really, so that's visible and the progress, which of course is urgently needed. Okay. So unless there are any others that wish to come in at this point, we're asked to note the information contained in the report and the need to focus all the efforts on the delivery of the 3% recurrent efficiency target in order to meet the requirements of the sustainability plan. Thank you very much, Laura.
Thank you.
Okay, so Claire, I think you're acting for Alison for the next part, is that right?
I am, yes, thank you. So Alison's on leave this week, so I have the pleasure of presenting her report. First report to consider is amendments to the governance handbook. I think it's fair to say that sometimes with these governance handbooks and constitutions, the only way we can test them out properly is by actually using them. And as the paper explains, we've come across a bit of a practical conundrum in terms of one of the areas in the handbook that is actually slowing down our decision making. So Alison's done some work to investigate and have a look at our options in terms of helping to unblock some of that difficulty, and the suggestion here is going to alleviate that. We are able to agree minor amendments, which I agree with Alison, this feels like a minor amendment at governing body. So the request is set out in the paper in terms of the adjustment to both the governance handbook wording and the terms of reference for the strategic commissioning committee, because that's where the adjustment occurs. So we're seeking agreement and support for the changes that are listed. I can take comments or questions, but I do think it's pretty self-explanatory in there.
Thanks, Claire. So any questions arising from this, Donna? Thank you.
Not specifically on that, because I think it seems very sensible and ultimately the right thing to do. And it's just to make sure, and I believe it will be under the terms for the Primary Care Committee, that a similar thing can take place there. So it was just, is that already ingrained and part of the terms of reference, and if it isn't, should we have mirrored it in some way?
Yeah, it's a really good point. I don't know offhand. You're absolutely right, though. The function that this refers to is performed by both of those committees. So perhaps, John, with your agreement, we could seek sign off for me to check that. And if we do need to make that adjustment, if you can give me and Alison license to do that at the same time. It seems a little long-winded to bring it back next time for the sake of just agreeing that here and now.
Yeah, if the governing body agree with that, then I think that's very sensible, Claire.
That's helpful, Donna, thank you.
Thank you. Okay, so I don't see any other hands up. Oh, so apologies, Jeff.
Yeah, thanks, Chair. Yeah, it's just really a question around the ICS now. I think there's, the governance handbook is really based around what we've had previously as a CCG, and I know it's been updated by Alison, but I suppose it's just really around whether there should be a specific section or caveat or reference to, as we progress through the year, we may well want to start giving some delegated authority to some of the subgroups from the ICS, and rather than having to go back and incrementally change the handbook, whether it would be useful just to have some sort of caveat or section right at the start that we can potentially approve that references that move and the migration to the ICS.
I think we'd need to be a little careful with that one. So for this year, we retain our statutory responsibility. So as you say, Jeff, we do have some licence to delegate responsibility, but ultimately that accountability would still sit with CCG. We are just awaiting final guidance, but we're in the process of developing the new set of constitution and governance handbook and all the other suite of information that will be for the ICS as well. So that's another area of focus. I think for me, it would very much depend on what sort of thing we were looking to delegate as well, because we would need to judge whether that falls into the same sort of category as this one, which isn't material and we could agree through governing body, or if it becomes something more fundamental that we would need the membership to vote on as well. So I'll pick it up as a point because I think it's a really important one that we need to be cognizant of that as we're starting to transition. And I'll see if we can do any forward thinking that kind of means we're not on the back foot if we need to do that, if that makes sense. Yeah.
Yeah, I mean, things like, for example, the committee structure. It's got all of the standard committees. It's got the governing body and the membership. But it seems wrong that there's nothing in there that actually references the ICS. Because there's definitely tension between us solely focusing on the CCG priorities versus being cognizant of the ICS and where that's going and the direction of it. And, this may be something to consider.
Yeah, so I think as a minimum, an explanatory paragraph that sets that context, which I would say is immaterial to the content of the document and purely sets context. And then as a more developed piece of thinking, if there's anything else we might want to do with that, yeah, I'm happy with that, Jeff. Yeah, we can take a look.
Right, thank you. Thank you all. So the CCG, as our governing body, is recommended to approve the governance handbook with the highlighted amendments as outlined in the report and appendix are attached. Thank you. Thanks, Claire. If we then move on to the board assurance framework paper, Claire, this is with you again.
Yeah, thank you. So governing body members will recall that we had the recent session to take a fresh look at our board assurance framework based around the priorities that we agreed for the CCG this year. There was a lot of feedback on the straw man that we considered. Alison's taken that away, worked with our internal auditors to come up with a revised draft that the directors have also been through and added some additional context to. And that's what's presented here today. So the recommendation is to review and ultimately approve the BAF, and we'll continue to use this as our working tool going forwards. But as ever, I'm happy to take any comments or questions, and we can look at those between meetings.
Thank you, Claire. So questions regarding the BAF, which I know we had a good amount of work in developing. It's good to see it coming back to governing body. Questions for Claire around this? I certainly had one, Claire, which was, I mean, looking at the numerical list, if I'm right, and my eyesight's not so good here, but it seems to list 1 to 5 a couple of times, but on the second rendition, in children and young people particularly, which is item 5 on the later sheet. It's really the gaps in controls, the action plan, the risk owner, it's simply populated with to be confirmed. I just really want to check that this item is actually being progressed. You know, it's not good enough at this stage, clearly. And are we making progress here, and will we see it? When will we see it populated?
Yeah, I sense that there's a timing issue there in terms of the cut-off for submitting the paper and receiving more feedback from the risk owner. So we will definitely make sure that any gaps like that are filled. They won't be there for next time.
Thanks, Claire. And Donna.
It's sort of in similar vein, John. It's in relation to one of the risks that are on there, and recognising that this is something that, you know, what is possible to achieve in 12 months is very difficult. But it's the inequalities in cancer survival, which is down as a purple risk. It describes it as catastrophic or whatever in part of that, if I'm, again, struggling to read a little bit down on the paperwork. But I would have anticipated some more detail around that for that risk that is on the list as it's been categorised, really. But obviously accepting it's kind of work in progress, and we're building on. In fact.
Yeah, I don't know whether Julie wants to comment on that one specifically. I'm just looking at the numbering and running down the list, and I think what's happened is that we've got a GBAF, and then we'd got a second sheet on our working sheet, which went down to the next layer of director level risks. And I was just scanning down to see if I recognise them, and where we start at 1 again, I think that hits our director level risks.
Right.
Julie, I'm sure will confirm, because you know the cancer one inside out and back to front.
It is, and the reason that is purely because it's the first time we've tried to tackle this, and with the place-based honour. So it isn't that we're not working on it. It's been taken. It's gone to the cancer strategy group in the first instance to do the deep dives on understanding some of the inequalities. It's more our mechanisms for taking that forward, because clearly it is going to require a place-based focus. So it's more about, please don't, we absolutely are on it, understanding it. It's then how we take that forward that's the bit that still needs to be clarified, not the initial, well, the analysis has been done. It's now the deep dive to understand the underlying causes, and then it's how we manage that through our place-based arrangements to get the delivery of improvement. Okay.
Thank you.
Thank you, Julie. Thank you for that. Audrey.
Yeah, hi. Very much in a similar theme. The numbers were high. I looked at quality and safety one, where it says the CCG fails to commission safe quality services for the population. There's a risk that patients will come to harm. And again, when I looked at the mitigation, I just wondered, was it detailed enough to bring that figure down and give us all assurance? I think that's what I'm saying.
Okay, yep, we'll take that back. Thank you.
Thank you, Audrey. And Mike?
Thank you. Again, similar sort of thing. I felt it's work in progress. I struggled really hard to try and work out some of what's going on, whether it's print size or I'm going blind, which is true. I found it quite hard to interpret at times. But I think we have to work on this as not as a finished item, but something that is that is ongoing, and I think there is still a lot of work to be done. So I'm actually really impressed that you've actually got this far. So thank you for all the people's work, but I don't think it's a finished item yet, and I don't think it should be, because the moment we say it's finished means that we failed. So
No,
I'm happy
you're
for
right.
it to be semi-complete still, so it remains open and adaptable. Thank you.
The board assurance framework is absolutely a live document. It will never stand still, because you're right, if it does, then something's gone terribly wrong. Some of those bits of feedback are really helpful. We'll take that back. We'll continue to refine. I think for me, it's just about making sure that people are content that we're talking about the right things here. So these are supposed to be the key risks to us delivering our strategic priorities. Certainly my review, when I went down the first lot of numbers, I took the second lot in a slightly different context, but certainly that felt to be a fair reflection of the conversations that we'd had and the areas that we wanted to make sure were on there. So we'll keep working on that detail, because yes, we need to be able to give sufficient narrative to be able to describe those scores that we've assigned, and for governing body to be comfortable with that.
Thank you for that. And Jeff.
Yeah, I mean, I think the BAF is obviously a statutory requirement, so we are audited against the use of the BAF. We have to provide assurance to the auditors that we are using it. I think it's a really useful step forward for us, but in taking on board Meredith's points, I do think that going through the BAF, with the committee structure we've got, we could easily segment some of those pieces of mitigation to those subcommittees and say, give us assurance each time you meet that your mitigation meets that. And then what we're not doing is giving a load of admin work to execs to say, can you update this mitigation? And I also just wanted to mention one of the things that the external auditors said. When they came in and they audited our relationship or our tension with SAF in terms of us as a commissioner, they weren't satisfied with the outcomes, but actually what they did say is that they couldn't really see what else we could do. And I think the reality of it is sometimes it's just about reconfirming that you've looked at it, you believe in what you're doing and how you've done it, and you just can continue to do it, and it doesn't really require any more further update than that, really. So I just really, I suppose, wanted to put that bit of context that actually we're doing some really good stuff here.
Yeah, that's helpful, Jeff. You're absolutely right. We can never mitigate every risk down to zero. That's just not how the world works. But we've got to be satisfied that collectively we can live with the levels that we've got. So I'll take that bit of feedback back to Alison as well about how we make sure that we are using that committee substructure a bit more effectively. I think that's really helpful.
Thank you all. Excellent. So the governing body is recommended to review and approve the BAF as of the 30th of June 2021. Perhaps we should say as of the 14th of July 2021. But, okay, thanks very much.
Thank you.
Thank you, Claire. So we next on the agenda of the reports regarding the integrated care system update. Claire, I don't think we have Nikki on the call, do we?
No, Nikki's on leave.
Nikki, yeah, okay.
I'll take the report as read. I know that last time we brought an update to the committee, it was very well received up to the board. And so I asked Nikki to do something similar this time, but to produce a bit of context in terms of what's going on in ICS land, but also that really valuable update on the pledges. So the report's there for people to have read, and I'm happy to take any comments or questions.
Okay, open to discussion and questions. Clearly the report has articulated the details well. Meredith.
Thank you. Yeah, no, it's a very helpful report. So thank you, Claire, and do pass on our thanks to Nikki as well. I had two queries. One was around Pledge 8. people and communities work, and I'm not getting any sense of what the work is, or who's doing it, or timescale, or nature, or anything in particular. And I did see from the NHS EI ICS design document that that there's great expectation that we need to be doing more and better around involving people and communities. So I just wondered if you're in a position to tell us a little bit more about the work that's underway under that pledge.
Yes, certainly. Thank you. There are a number of layers to communication and engagement for the ICS at the moment. So we've got one channel of work which is focusing on internal communication. That's both at board and director level, and then thinking about how we push messaging further down into our teams, which is really, really important. And then we've got that more external facing work, which is all about how do we get the right messages out to our general public, and how do we involve them in the right discussions at the right time. So the internal work, there are a series of things going on at the moment in terms of development sessions, workshops, various things programmed, not on a hugely onerous basis, but certainly on a regular basis to keep people dialed in. We've also launched very recently a bi-weekly system newsletter. So rather than just having individual organisations, we're starting to have that collective communication, which I think is going to make a really big difference. In terms of the patients and the public themselves, Edna Bowenpong and her team are currently working on an overarching plan and strategy for the ICS. We've been having conversations actually over the last few days, even Meredith, about how we get that right, particularly in the context of a discussion that John and I were party to last week at Health and Wellbeing Board in Shropshire, where we're really cognizant that what we don't want to do is bombard people with lots of messages or similar messages and basically cause confusion or fatigue in terms of what we're throwing out. So for me, I get a really good sense from talking to Edna that this is a coordinated and planned approach rather than scattergun, which I think is going to be really helpful. The other work that we're also talking about at the moment, and I'm involved to a lesser extent in that, but from different aspects, is how we have that overarching statement for us about what's our strategy and what do we want to achieve as an ICS, and then we frame all the good stuff that we're doing as part of that. So rather than hospital transformation programme becoming this entity on its own that sits outside of everything else that we're doing, we're looking to say, well, okay, that's great, but that's part of this wider aspiration. So we very much make the links between that, the focus we've got on our community work, our primary care development. So it all becomes part of that systematic approach rather than lots of bits and bobs. So probably nothing tangible to give you at this point, Meredith, where I can say here's the plan and here's the timeline, but be assured that that's in progress. All the right drivers are there to make that happen and make it coherent and cohesive. And I think it says, I'm just checking in the paper, yes, the other sort of key thing for cementing that moving forward is the AGM that we're planning for October, which will be that kind of first formal opportunity for the ICS to talk to its public and really start to launch what's going on. Does that help give a bit of context?
Yes, thank you very much. Yeah, that's all great, Claire. Thank you very much. I'm not quite, as you say, there are so many lenses and layers and complexities around what we're talking about is a large number of different relationships with different people, or indeed different relationships with the same people, and it needs to be tied down and scheduled and planned and so forth. Steve Trenchard, and I'm involved in it a little bit, is doing quite a lot of work around Steve will be able to tell us more about it, around how we do involve our population in the work that we do. And I just want to make sure, Steve, you'll be able to help me. I know whether that work is very much built into the work that you've set out there, Claire, because I'm slightly anxious that they're slightly out of kilter with each other. So there was that point really. I did have another point, but I don't know if we could just pick that one up first.
Yeah, we'll come back to you, Meredith.
Yeah, I'll let Steve comment.
At that point, it would flow nicely.
Yeah, thanks, Meredith. I think we were aware at the beginning that there might be a possibility of colliding here. So a quick conversation with Edna right at the beginning of this made sure that we weren't doing that. I think what we're hoping to do just in the involvement piece is, and we've located this also in the partnership boards, is to do some work building on the good examples of co-production in the system. You know, we heard earlier about maternity voices. We've got the good work that's going on the SEND agenda. We've got great work that's going on with Health Watch and possibly looking at their national platform. And we've got some really good work as well going on in the benefits space with local authorities. So we've got good stuff to work with. But what we want to try and do is to get a more consistent approach. And obviously with our big six and then all our other schemes of transformation is to make sure that the citizen voice is right at the heart of that. That's a commitment that we've made through our pledges. So the workshop is about trying to take us through a series of steps in order to be able to be ready for April the 1st next year to really go live with that pledge.
Okay, brilliant. Thanks very much. Okay, and my second point, separate, was around the climate change work, which I think said was going to be completed the end of June. I just wondered if there was an update on that.
I confess, Meredith, I haven't seen that update yet. It's that one's being led by our local authority colleagues. We have had a conversation about it fairly recently at chief execs, but I'm still waiting to see what's come back on that one. It may be. I think it's all right. We were looking at the draft agenda for the ICS board this month. I think that it may be on there, so it's imminent.
Great. Thank you very much. Thanks, John.
Thanks, Meredith. And Mike.
Thank you. I remain a little bit confused. I read. I don't know how to. I'm trying to say this very carefully, and I'm not sure if it's going to come out the right way. Primary care is still very neglected in all this sort of stuff. It may well be developing, but I don't know with whom. I think when you talk about working with people in communities, that should include primary care, and I state primary care as a whole rather than doctors, because it's not just that. And I do agree with Lynn, it is also about Health Watch and all that sort of stuff should be involved. The pathways I find still very difficult to work out what's going on. I'm not always convinced that a newsletter is the best way of doing things. It's far better, and I do go back to co-working, that especially in COVID when there were direct communications, i.e. meetings, albeit very short. There are a lot more things were done and were done far quicker than having to read it in a bit of paper and then try and work out. At least with some sort of online face-to-face meeting, you got quicker results and quicker answers, which makes working things far quicker and less cumbersome. So although I thought the paper overall was very good, I still have quite marked concerns about how these things are going to be fed down from the ICS to the communities, to the doctors, to the other people in primary care, because that still, from what I've read, I still can't see what the answers are. Perhaps I'm being naive, but I'm really not. I really have slight concerns, because otherwise people just go, oh, it's the CCG under another name. And if we're doing it properly, it shouldn't be. It should be something better.
Thank you, Mike. Your comments on primary care. I know that we, as a CCG, have a practice bulletin that goes out now fortnightly rather than weekly, and that dovetails with the ICS Collaborate newsletter. And I guess newsletter is as good as who they get to, really, Mike. And I think it's a duty on all of us in the practices to make sure that we disseminate the newsletters disseminated properly, because not everyone can get to every meeting. So I think there is a need for newsletters, but I guess communication takes many forms. Claire, did you want to come back on the part regarding primary care within the ICS? Was that your hand about that, or was it?
Sorry, I was looking at Claire S then. Yes, John, thank you. Just before Deborah Shepherd went on leave, I was in a meeting with Mark, Neil McKay, Ian Rummins and Ian Chan and Jane Povey, talking about how primary care gets involved at what levels, particularly not just PCN, CDs, primary care, GPs, practice managers, other health professionals involved in primary care, to start and look at, and Ian Chan raised it very well, that a lot of primary care is around operational, and we need to move into that kind of tactical and strategic, and where best to get that voice and make sure that's heard. So that's a developing piece of work alongside the ICS conversation, because I know from my work with primary care that they're really concerned that the ICS is going to be a different vehicle and they're going to be cut out of it. And if we're going to be successful as a system, we absolutely need primary care front and centre. It's not going to work without it. So they need to be a very strong voice in that. So just to reassure Mike that we are having those conversations. Our primary care clinical lead is plugged into that. As that develops, we will bring information through the board and through the Primary Care Commissioning Committee.
Thanks, Claire, and thank you, Mike.
Sorry, I don't know how that's getting anywhere. That's just going around committees. How's that getting to general practice and in its broader sense? That's just going around in circles. So I'm not sure. I'd like to know what this development is, and if I can help, I would like to know, because I really don't know how it's getting there. So I apologise for being naive and apologise for being stupid, but I don't get it. So if you can explain to me, and I'd love to talk to Claire. I tried to talk to Janet about some of this, but unfortunately we had issues with communications. But I would like to know some more details, because I really don't understand.
Mike, I'm happy to have a conversation outside of the meeting with you if you like.
That's absolutely fine.
Also with Deborah, but just to reassure you that the leads of the PCNs, the LMC, have been involved, along with Deborah Shepherd, Jane Povey, I believe, and Mark Brandreth and Sir Neil McKay, and they're very much looking at how primary care will fit in. I think you're knocking at a very open door here, Mike. There's a great desire for primary care to be part of, recognised as an absolute integral part of this system, and including at place-based level. So, but yes, I am aware that there is a great deal of work going on along this line. So perhaps we could take that out of the meeting and have that discussion with you and link you in.
John, it was recognised that actually governing body members were probably outside of that conversation. Yeah. So I'll absolutely snap my hands off to get involved in that. That's great, thank you.
Great, thanks very much, Claire. Good, okay. So governing body members are asked to note the information provided within this report, and I'd say add to that and discuss them. So that we have done. Thank you. Thanks very much, Claire.
Thanks.
Now, the next paper is regarding the Armed Forces Covenant. Just to add, since the start of the meeting, I've just become aware that Ash Ahmed has a conflict of interest here. Ash is a member of the West Midlands Veterinary Advisory and Pensions Committee, which I've considered that. Thank you for declaring that, Ash. I guess you probably weren't expecting a paper on armed forces to come up, but it's to say that I think If all members are in agreement that Ash is present for the discussion and may take part in the discussion, but not in any subsequent decisions regarding the Armed Forces Covenant. Okay, if we're in agreement with that, I think, Claire, you were going to just briefly set the scene on this.
Yeah, just very briefly. For those of you that are not aware of this, this is based on the Shabazz report that was written by Professor Tim Briggs, and it was around improving veterans care for working armed forces and veterans, and improving NHS standards. The NHS made a commitment to the armed forces that all healthcare settings would provide services to veterans, serving officers and their families. When we were two separate CCGs, we both signed up to the Veterans Covenant, and we felt that it was pertinent to bring a refresh of agreement to the Covenant to the single CCG rather than the two separate, so that it can be minuted that we are signing up to this. And the recommendation from the paper is that Shropshire, Telford and Wrekin CCG do sign up to the Covenant.
Thank you, Claire. Good, so open for discussion. So clearly, Claire, one of the points within the paper really is that those in the armed forces and their families have a quality of access, because they're frequently moving around the country and may end up, moving between waiting lists and systems, and therefore it's to ensure that that doesn't cause inequalities for that group of our population. Yeah, and
it's not just that; it's also mental health as well, I think, particularly.
Yes, thanks, Claire.
Just to say that I very much support this as a way forward. I think to publicly make that declaration as a governing body is good, because it shows our commitment to these individuals and their families, which I think is really important. The context in our county as well, we have a number of really strong links with the armed forces, particularly through Robert Jones. We've got barracks within the county, so for me it just makes absolute sense to publicly make that commitment, and would definitely support the recommendation.
Okay, and thank you, Claire. And Jeff.
Yeah, thank you. I just wondered whether this was something that we should be promoting or going out to the media a little bit more proactively about, because it absolutely sounds like, as you said, Claire, something we should be supporting. I just wonder whether we should be a bit more proactive with that support.
So one thing that I do know is that NHS are just refreshing their structure around the Veterans Covenant, and actually there'll be over the coming weeks there will be more information and links with Acute Trust and other providers around this. So I think if we can link in, I'll speak to Edna about it and see how we can link in particularly around this piece of work. I know Sam's involved in it as well, so it would be really helpful.
If I may as well, I know this is one area that we'd already discussed being able to promote and get out there. We missed the timing a little because we've missed a couple of days recently where it would have been well placed. We had Veterans Day and things like that. We do have plans for, I'm just checking my diary now to make sure I describe the right thing. We're looking at a Shropshire Veteran Aware conference, which will be a multi-agency conference across the system. So certainly that's in its embryonic stages, but with governing body support today, we can fully commit to supporting that as well, which I think will be very good.
Thank you, Claire. And Steve.
Yeah, thank you. Gets my full support. It's probably noticeable that some of our providers are already signed up to this, NPFT, particularly from a mental health, and also in Stoke there's the Armed Forces outreach team there, and one of the biggest in the country. We have a large number of veterans in the north. it's great to hear, Claire, that this is an ICS, and I wonder whether this should actually be an ICS supported covenant, not just a CCG. I don't know whether that conversation's happening with chief execs, but it's not just about practices, it's the whole system, isn't it? And I think a couple of final points. One is we just looked at our pledges. So inequalities, veterans often face numerous inequalities, not least in the mental health, but also access and physical health services. And obviously there's the great work that's been done at RGH recently to meet that particular issue. And then also the economic impact. People coming out of armed forces often face unemployment and end up on the street because of the difficulties they challenge. So for me, it ticks a number of our priorities and pledges.
Thank you, Steve. And Ash.
Picking it from Steve, how do we expedite access to services for those who have moved areas or whatever? Is that possible to be done? Can that be done or looked at?
Claire, do you want to come back on that?
Yeah, we need to, now we've got this sign up, we need to go out and get an action plan in place that starts to look through the covenant and how we're going to support and manage that. So I've got some ideas, but things like flagging on the system when new patients come in or move into area, making sure that existing veterans and families are flagged on systems, and just making sure that's consistent across the county. So yeah, that'll be the next piece of work, Ash.
Thank you.
Great, thank you. And certainly, I'll just add from a primary care viewpoint, I know that several practices in the county are registered as veteran-friendly practices, and that's something available. The Royal College of General Practitioners facilitates that. It's available through their website, and it does give a great resource of information, such as alluding to Steve's comments regarding mental health needs for veterans and their families through Op Courage, which is a service available for veterans. So there's a wealth of information for those practices that sign up to that initiative. So, thank you. Okay, so I don't see any other hands. So good. Governing bodies requested to sign up to the Armed Forces Covenant as a new CCG. Okay, thank you very much. Super. So we now move into really the part of the agenda where there are papers for information only from the Finance Committee, Quality Committee, locality meetings, all the localities, the Audit Committee and Primary Care. The Strategic Commissioning Committee didn't have a written paper at the time that the papers were published or sent out. But I've been made aware that there will be a summary paper for the Strategic Commissioning Committee added to the papers and website. Ash, I don't know if you just wanted to verbally summarise any key points that at this point of the meeting from SCC.
Yeah, sure. So we had a number of papers in the last meeting on the 16th of June. Had papers April and May, elective recovery delivery H1 plan, and we discussed the performance report presented by Dr. Davis, identified system challenges in terms of diagnostics, endoscopy, ultrasound, mitigation in place highlighted, and there's a fair amount of work being done to address impact from COVID. Had the IVF policy update, the enhanced health and care homes and community support as a business case presented. The digital element of that case is working in place. However, it's not yet received the project management altogether. No update has been provided as to the progress of the pilots taking place at Telford and Wrekin. There's a paper on flash and glucose monitoring, and also the Optum Accelerate Switch program. And for it to be delivered in primary care subject to further system ratification, and also there's a paper on audiology services and also community vasectomy service. Any questions on that, or Steve, how can you come in and add some more details?
Ash, I mean, there will be a written summary that's appended to the papers, but unless there are any specific questions, Meredith.
Yeah, thanks very much for that. Yeah, just had a quick look at the summary report that was sent around during the course of the meeting today. And obviously didn't get a chance to look at it properly. Just to say that it hasn't got the right dates on it, or indeed the right committee.
That's isn't it?
Well, what am I saying? It refers to joint committees, and of course it's a single committee. But anyway, that's just a minor detail.
Yes, I think it was taken off a template, wasn't it?
Yeah.
Unfortunately, not repopulated correctly. So that needs to be amended before it's placed on the website, please. Thank you, Ash. Okay, moving into any other business today. Not been notified of any specific items. Thank you. Okay, so the date and time of the next meeting is Wednesday, the 8th of September. Time to be confirmed, and also venue and mode of meeting yet to be confirmed. Watch this space. And so we move. So I now resolve that representatives of the press and other members of the public be excluded from the remainder of the meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest. Section 1, paragraph 2 of the Public Bodies Admission to Meetings Act 1960. And at this point, I close this meeting. Thank you. So if we